Dear colleagues, good afternoon. My name is Irene Lambrinoudaki, and I'm chairing this webinar in my capacity as Scientific Director of the European Menopause and Andropause Society. On behalf of EMAS, I would like to welcome you to this joint activity with the European Society of Endocrinology. Our joint effort was to present common clinical topics that clinicians will have to deal with in their practice and to have a forum for an active discussion at the end of the presentations. The second part of these webinars is dedicated to the menopause, its short and long-term implications, and how we can best manage each of them. I would like to pass my microphone to my co-chair, Dr. Antoan Stefan Sojat, who will express a welcome.
Thank you, Professor Lambrinoudaki. Dear everybody, hello. My name is Antoan Stefan Sojat. I'm the current ESE committee co-chair, so the early career branch of the European Society of Endocrinology co-chair. It is our amazing pleasure to be here and to enjoy this very successful collaboration. Yesterday's seminar was a rising success, and we will continue with this today and hopefully many more seminars in the future. We want to also ask you, please, that for the questions and for the discussions, you use the Q&A function and not the chat function, because it's much easier for the speakers and for all included to see the questions. And also, I, of course, invite you to enjoy our lectures. And I'm very thankful also to Professor Lambrinoudaki for this honor to be here today. And I will let her introduce our first speaker for this seminar.
So our first speaker is Professor Andrea Giannini, who is a professor at the Division of Obstetrics and Gynecology at the University of Pisa. He focuses in gynecologic and reproductive endocrinology and menopausal medicine. Academically, he has performed translational research on rat models in the field of menopause and neuroendocrinology of aging, and on the effects of menopausal hormone therapy on neurobiology and neurotrophic factors involved in menopause transition. He's also involved in clinical studies on endometrial and uterine cancer and precancerous conditions. Concerning his clinical activities, Andrea is involved in robotic surgery for benign pathology, reconstructive and oncologic gynecologic surgery, and also he's involved in the development of surgical techniques in pelvic floor diseases, as well as in computer-assisted surgical simulation of pelvic procedures. Andrea has published over 100 original papers on high-impact scientific journals and over 20 book chapters. So the title of the presentation is Short-Term Effects and Long-Term Risks of Menopause. Andrea, the floor is yours.
So thank you so much for the opportunity to contribute to this webinar. It's a great informative event. So thank you for this kind presentation about short-term effects and the long-term risk of menopause. It's something very difficult to complete in 20 minutes, but I will try. What is interesting is that some percent of women will experience menopause and climacteric after the HPO axis function is impaired over the time. So what is menopause? Menopause is the result of many genetic factors that can impact in the ovarian function and by the hypothalamic function. So hypothalamic aging determines a follicle loss and so a functional ovarian aging and functional withdrawal. So every woman will experience this event after the loss of ovarian follicles after the end of a fertile period. So when menopause occurs in women, there is a kind of trend around the world for experience menopause. So you can see that in Europe, mean age for menopause is 51 years, but there is some variability among all the nations of the world. So it depends about race, about social economic condition, and many other factors. Anyway, all women will experience the menopause. When the menopause occurs, there are a lot of systems that are unable to have a normal function after hormonal and estrogen withdrawal, the central nervous system, the skin, the mucosal, the hair changes, the weight and metabolic changes, musculoskeletal system, urogenital system, and sexual function. And so it's very interesting that about the central nervous system, everything starts from this station, from the HPO axis. So it's interesting to note that at the central level, there is a lot of modification and impairment of neurosteroids, neurotransmitter, and hormonal withdrawal. So if you can see, some of these events are related to estrogen changes, but some of that are implicated in the androgen decline. So it's important to note that there are several neurotransmitter, neurosteroid, and hormonal molecules that are invalidated by the low level of estrogen, and at the same time low level of testosterone, DHEA, and all the androgen produced by the ovaries and the adrenals. It's interesting to note that the menopause and the aging of women is a sort of step processes. There are, if the start of the menopause is an event that can occur maybe at 50 years of age, there are early symptoms, middle symptoms, and late trouble and problems. 1/3 of these patients are very symptomatic patients, so with heavy symptoms that can occur, for example, during climacteric change, and maybe the most important and relevant symptom at the start of this change is of flushing and night sweat, and vulvovaginal atrophy, the sexual dysfunction, and anxiety and mood disorder. But there are many important long-term problems, such as prolapse, urinary incontinence. In general, the wronging of genitourinary syndrome of the menopause and the cardiovascular disease and metabolic syndrome with the osteoporosis and the fracture, cognition, and dementia. So there are several problems that can occur in different age of a climacteric patient. What is important to note, to point out, is that the change of the women are personal, because women in general may be differently vulnerable to the menopausal change and symptoms. I think it's very interesting because the concept of vulnerability is something that is special and is studied in the last decade. It's important because the symptoms and the biological change sometimes are conditioned by socioeconomic factors, psychiatric history, but also psychological expectation and some pharmacological factors that are impacted by maybe therapy and chronic therapy, and maybe for depression or anxiety and so on. And the vulnerability of the women is something that depends about interpersonal relationship. It's very difficult to separate the personal aspect and the biological change of a woman. And also some personality traits that are important. These determine the AV and the presentation sometimes of the symptoms. It's important to point out also that menopause is not only a biological event. It's a sort of social and family transition to the elderly age. So maybe for the first time, some women can realize that the aging is started and something is really changing in their biology and their life. There are also many important social and family events during the climacteric period of the women. So the retirement, the elderly empty nest syndrome, the birth of a first grandson, maybe the death of the husband, and the health deterioration. So it's very important to think about the women that is not an island, that is something more specific and more important with a constellation of factors that are biological and personal and emotional. But if you want to talk about symptoms, it's important to note that there are common symptoms that have maybe an onset that can have a particular onset and a duration. So maybe hot flashes maybe can occur in the later transition of the menopause, and usually can last for 6-10 years. And it's different for maybe the symptoms of poor sleeping, maybe some mood change, or by the vaginal dryness. So each symptoms is something that can occur in a particular moment of climateric transition and have a particular duration. This is an interesting slide concerning vasomotor symptoms, and we must understand that the duration of the symptom are peculiar, maybe of the ethnicity and of the race. So different women in different countries can experience the same symptoms maybe for the first time in a particular period of the menopausal transition, but it's important to note that this time can be the time of experiencing these symptoms. It's different along the early and the late menopausal transition until the postmenopause period. One of the most important change of menopause is the cardiovascular and the metabolic function. So there is a change of insulin sensitivity. So there is a storage of fat, and so the change of some pancreatic function that are important for the cardiovascular problem. My colleague will talk about that extensively in the next presentation. But what is important to note is that the menopausal transition is characterized by not only a little change of the weight or the percentage of body fat. It's important to note that the most important change is the visceral and adipose tissue that is growing and is proportional to the reduction of estradiol and the rise of FSH. At the same time, in menopausal transition, there is the loss of some physical activity and maybe the reduction of total caloric intake. So it's interesting to note that the visceral fat, the distribution of the fat is different, and this is something determining the improvement, the increase of risk factor, cardiovascular risk factor for women that can reach and even be bigger about respect to men after the menopause. So about the metabolic change, there is some studies that are fascinating that show that metabolic and immune signaling during the chronological and endocrinological transition across the menopause is something important even in the brain. And this is an event that can start when there is a premenopausal condition, but can be even wrong in the menopausal onset and then in postmenopausal period. So, but I repeat, my colleague will talk about this topic in a very extensive way. Another long-term problem is the prevalence of dementia. Dementia is something that rises dramatically after the menopause or during the aging of the patient. So is a phenomenon, is a pathologic entity that starts after the menopause, can rise if not treated, if there is no prevention, is something that rises dramatically across the decade after menopause. The prevalence of dementia is growing also because the population is aging, is true, but there is several causes for dementia. The most important, is Alzheimer's disease and the vascular dementia. Anyway, people with menopause, the women with menopause are more vulnerable to this event, and so we can perform some prevention and to treat very, very early if occurs. Another long-term problem is the onset of osteoporosis and the sarcopenia. You know that the low level of estrogen can change the balance of osteoblastic and osteoclastic activity. So osteoclastic activity without estrogen are more propensed to have an action on the bone. So the resorption of the bone is increased, and osteoporosis can onset if not treated or not prevented. The same stuff is for sarcopenia. Sarcopenia is something that can be touched even by lifestyle factor such as inactivity, the nutritional status, such as old women with mental dementia and important problem of age, and even hormonal assets. So it's important to do physical activity to improve. Many guidelines now can stimulate menopausal women to have a normal activity and to prevent this kind of event. Another change that is important is the change about structural change of the genitourinary system that is defined as a genitourinary syndrome of the menopause. It's very interesting because these kind of changes of the genitalia, of the external and internal genitalia, the vulva, and the mucosa, the vagina, it's interesting because some of these changes are determined by estrogen withdrawal, but the most important are determined by androgen withdrawal. So it's relevant, it's crucial to understand this topic and to treat this patient with both of these compounds if needed. When we talk about the pelvic floor changes and age, it's important to note that something starts maybe with delivery and with the childbirth, because there is the first step, the first moment of the damage is the pelvic denervation, followed by a devascularization of the pelvic floor fascia and the structure. This anatomic modification determine a decline in the mechanical strength of these anatomical ligament, fascia, and musculoskeletal element. In general, we can achieve a dysgenergic pelvic floor dysfunction that is very difficult to treat because there is not only a cause, there is not only a reason for this problem. And it's important to note that this kind of aging of the pelvic floor is something that can occur for example, in the urinary tract. So it's important to underline that during menopausal transition and even after during the late postmenopausal period, a woman can experience maybe infection, maybe a recurrent infection of the bladder and urinary tract, and also the bled parent syndrome with dysuria and maybe trigonitis and cystitis that sometimes have no bacteria agent, but maybe can be interstitial cystitis and so on. These can lead to a sexual disorder, discomfort, sexual pain, so impairing the sexual function in general. But it's important to focus that the sexual dysfunction is not only a problem of the pelvic floor. It's something that starts from the central nervous system. After the lack of estrogen, yes, but more important, the androgen, because women can experience desire disorder, arousal disorder, so the motivation. Some of these women can experience orgasmic disorder, so the difficult to reach a real orgasm like the past, and in general, the chronic pelvic pain. So it's important to inform patients that some of these events are related to the pelvic floor change and organic musculofascial changes and deterioration, but it's important to inform that some of these symptoms are related to the central nervous system deterioration and aging. For the conclusion, we can affirm that the menopause in general is something that can determine in women a sort of frailty of specific, personal specific vulnerability. Maybe there is the onset of disease and many changes in lifestyle even the loss of sexuality. So it's important to inform the patient that is a biological, a personal, and a social event that can be resolved maybe with the menopausal hormone treatment when there is no contraindication and if a woman desire this kind of treatment. But I think that the most fascinating aspect is that there are different phenotypes of menopausal women. There is a young woman who can experience premature menopause. There is women undergoing surgical menopause. There are menopausal women that are healthy, but there is menopausal women that maybe can have hypertension or metabolic syndrome and cardiovascular risk. So it's important to treat this patient, personalizing the approach and informing that for each of them, there is a therapy if she is interesting, if there is no contraindication, absolute or contraindication, that can resolve the symptoms and maybe can be a sort of prevention of aging and maybe the main pathology of the aging. So every woman, if treated, if we after a good evaluation can have a therapy, it can be helped for her transition to the aging with several therapy that can be systemic or topic. So thank you for this opportunity, and I think I am available for any question and clarification. Thank you.
So thank you very much for your amazing lecture. And I'm also happy to say that we are having some questions in the Q&A. The decision is in general to have all of the Q&A session after all the talks. So we will be continuing with the talks right now. And it is my great pleasure to introduce the next speaker, a great colleague and a great friend, Dr. Elena Armeni, a dedicated reproductive endocrinology specialist, spanning career from Athens to London, where she serves as an endocrinology and diabetes consultant. With expertise in reproductive and cardiovascular endocrinology, Dr. Eleni focuses on managing postmenopausal women and those with PCOS. Her PhD, in collaboration with the University of Athens, delved into cardiovascular endocrinology in menopausal women with PCOS history. Holding an MSc in diabetes mellitus postmenopausal transition from University of South Wales, she explores sex hormone connections to cardiometabolic conditions, and she holds leadership roles in various endocrinology societies. And I'm very happy that she's here today. We had great collaboration for a long time, and congratulations also for being a huge part of organizing this series of webinars. And we will begin now with your talk, implications of menopause for cardiovascular health. The virtual floor is yours.
Thank you, Antoan. Dear organizers, dear committee, Prof Lambrinoudaki, thank you for having me here today. I will start discussing a topic that is very close to my heart because my whole academic life until today has been focused on the cardiovascular health in postmenopausal women. And for this purpose, I will start straight away with a general, very basic introduction of the stages of menopause. Menopause can be divided into the very first stage, obviously the pre-menopause, which is the entire reproductive period from menarche until the final menstrual period. Perimenopause is the time frame that begins from the first clinical, biological, and endocrinological features, so when they become apparent, and completes 12 months after the last menstrual period. The transition itself is the time of lifespan after those 12 months. So time before the final menstrual period, when variability in the menstrual cycle usually is increased. And the postmenopause is whatever remains thereafter. With regards to other ways to differentiate the menopause, we have obviously, as already discussed in the first presentation, the natural, the spontaneous, or the induced, which can be surgical or iatrogenic, as well as the premature or early menopause. More details with regards to these definitions you can find in the position statement of the European Menopause and Andropause Society with regards to the definitions. And the title is the Essential Menopause Curriculum for Healthcare Professionals that you can easily find online. The implications of the menopausal transition we have already heard about, but what I want to focus on are the hormone changes which can trigger cardiovascular disease. There is sufficient amount of data to support that some of these implications are interlinked, and in particular, there is data over the last 10 years to support a link between vasomotor symptoms and cardiovascular disease itself. But sleeping habits can also contribute to a poor quality of life, and secondarily, because of this poor cardiovascular health, there is also some data linking osteoporosis and cardiovascular disease, but we will try to focus on the basic association between the transition into the menopause, the related sex hormone changes, the vasomotor symptomatology, and what it brings to the cardiovascular health of the woman. Climacteric symptoms, it's worthy to define, because during my experience as an endocrinology consultant, I have met many colleagues, trainee level, that have difficulties to define what are the crucial, the outstanding symptoms of a postmenopausal or perimenopausal woman. So in particular, what we need to pay attention to is not necessarily the brain fog, which, yes, of course, it can come along, but it's first of all the vasomotor symptoms, the hot flashes, night sweats, and sleep disorders. This consists the primary indication for any kind of treatment you might want to offer to your women. More on the treatment you will hear about on the third talk of this webinar. With regards to other symptoms, the second big group is anxiety and mood disorders like irritability, panic attacks, mood instability, loss of interest for daily tasks, and then again, somatic symptoms. All of the remaining symptoms you might have heard being attributed to the menopause may to some extent be linked, but they are not fully confirmed. So we consider these three groups of symptoms as primarily the presenting climacteric symptoms, which most commonly would be anticipated in a woman around the time of the menopausal transition. However, the variety is likely to differ from woman to woman. So estrogen deficiency and then showing apparent hyperandrogenemia has implications for the cardiovascular health as proven by in vitro and in vivo data. The hormonal changes and aging itself result into a change into estradiol levels. Obviously, the ovaries stop working, estrogen drop. The aging itself also contributes to a lowering of the sex hormone binding globulin levels. And subsequently, what happens is an apparent increase, apparent relative hyperandrogenemia of the androgen to estrogen ratio. The consequences, the main consequences of these hormone changes are impaired fibrinolysis, visceral adiposity, insulin resistance, and this relative hyperandrogenism. We are anticipating, because of visceral adiposity and insulin resistance, a degree of metabolic dysfunction, oxidative stress, and low-grade chronic inflammation. The impaired fibrinolysis can contribute and will contribute eventually to atherosclerosis. The aforementioned changes will contribute to endothelial dysfunction. The relative hyperandrogenemia will also contribute to the endothelial dysfunction. All of those changes together contribute to the more rapid progression of atherosclerosis after the time of ovarian senescence. In vitro data suggests that estrogen is important in order to keep healthy vessels because it contributes to angiogenesis and vasodilation, in order to regulate the degree of fibrosis by reducing the migration of fibroblasts and the related proliferation, as well as the deposition of collagen, Estrogen is also important into the regulation of the life of mitochondria, as it has an anti-apoptotic effect and reduces reactive oxygen species production and improves the degree of oxidative stress. By these actions of estrogen, it is anticipated the lack of estrogen is going to contribute into a progressive deterioration of the vessels, structurally, functionally, but also progressive deterioration of the levels of cardiovascular risk factors, like blood lipids, like blood sugar, and even blood pressure. The postmenopausal sex steroid milieu, which is what we have discussed already, this relative hyperandrogenemia, has been associated with abdominal and visceral fat increase. In particular, the body composition changes after ovarian senescence with an increase in total fat mass, increased visceral abdominal fat, as well as subcutaneous abdominal fat. The storage of fat in ectopic locations starts becoming more apparent. Fat is located now in the liver, skeletal muscles. The peripheral fat starts being progressively reduced, whilst there is a reduction in the total and peripheral lean body mass. Remember the discussion from the previous talk with regards to sarcopenia. The visceral adiposity tissue changes, which are described nicely on this figure, result in a sense into oxidative stress and inflammation. These are the markers that are implicated, and the final outcome is one: insulin resistance. The postmenopausal loss of estrogens together with aging results in an increase in the caloric intake from day to day, as well as a decrease in the expenditure of energy. Ultimately, those changes contribute to an increase in body weight. Estrogen deficiency has known effects from in vitro and in vivo studies on the metabolism of the woman, and in particular, menopause and aging have been linked with reduced physical activity and mood disorders, as well as increased prevalence of comorbidities. These lead to lowering of muscle mass and energy expenditure, with an ultimate result, the increase of body weight, as we saw earlier. The loss of estrogens because of discontinuation of the ovarian function changes the action of the insulin, as well as insulin secretion and degradation. The result is, once again, insulin resistance, but also failure of the pancreas to meet increased insulin needs. And that, in practical terms, means higher risk for incident type 2 diabetes. All of these changes contribute into the development of cardiovascular disease and increase the risk of cardiovascular disease after the menopause. Menopause has known effects on cholesterol levels. According to the Lifelines cohort study, where 63,466 women aged 18 to 65, and from those, almost 40,000 were premenopausal, it has been evaluated that postmenopausal women, which stands for the green line in both charts, exhibit after the age of menopause, so around here, a sharper increase in levels of total cholesterol in comparison to the remaining groups, as well as a sharper increase in levels of LDL, low-density lipoprotein cholesterol, in comparison to the remaining groups. The lipid levels also change according to menopausal status, as shown in this analysis from a group in Thessaloniki, where we can observe that comparing a large number of premenopausal women versus postmenopausal women and men, there is a significant difference and actually a stepwise increase in the values of total cholesterol between premenopause and postmenopause, which, if you observe closely, appear to be even higher than the equivalent number that stands out for the male group. Triglycerides also increase after the menopause, and the same is valid for LDL cholesterol. In the meta-analysis of 66 studies and 114,655 women, it was estimated that after the menopause, the total cholesterol levels increased by 22.4 milligram per deciliter. LDL-C cholesterol increases by 17.4 milligram per deciliter, triglycerides by 23.9, whilst HDL cholesterol does not really change in quantity, but it changes in quality. The functionality decreases after the menopause, and the protective effect of HDL originally available, present in premenopausal women, is lost after the menopause. Hypertension also appears to be far more prevalent in women after 60 years of age compared to men. This group is represented by the orange bar. So in women, we have the fantastic, impressive percentage of 66.5%, whilst in the male group, we have 63.1%. You can see significant differences in the previous decades of a woman's life. The effect of menopause on the blood pressure can also be explained from in vitro and in vivo data. We have already explored how menopause and aging through inactivity, mood disorders, and sarcopenia contributes to weight gain. On the other side, the estrogen decline affects the lipids and induces insulin resistance, as we discussed already, contributes to chronic inflammation, but also has a direct effect on the vessel itself by activation of the renin-angiotensin system, increased angiotensin 2, endothelin 1, decreased nitric oxide synthase. That results into the known changes of the vessels at the time of the menopause: oxidative stress, vascular cell proliferation, vascular wall inflammation, arterial stiffness, and endothelial dysfunction. Atherosclerosis is the end outcome. Ischemic heart disease and stroke can hopefully be prevented. There is an interplay between menopause, hot flushes, and cardiovascular risk, according to recent data, where it has been shown that vasomotor symptoms, but persistent or moderate to severe, are actually directly associated with many of the aforementioned cardiovascular risk factors, and these risk factors contribute to deterioration of the cardiovascular risk. Implication upon the cardiovascular risk data from human studies. We will go through this in order to give a good idea of exactly the changes that are taking place. So we have already discussed about deterioration of endothelial function, and the study from 2016 showed that it is the relative hyperandrogenemia, the higher androgen levels at the time of the menopause, in comparison to estrogen, of course, which contribute to the further deterioration of the endothelial function. Also, arterial stiffness, estimated according to the carotid femoral pulse wave velocity, changes between the premenopausal age, so more than 1 year before the final menstrual period, changes sharply, increases sharply within 1 year of the final menstrual period, and starts slowly declining thereafter. The vessels themselves also change with regards to the intima media thickness. So with regards to comparing the early premenopause with the premenopausal year, early perimenopause with the premenopausal years, we have a slight thinning of the vessel wall. At the late perimenopausal stage, the intima media thickness starts increasing in order to start regulating itself, decreasing, thinning later on. Hormone replacement therapy is a big topic that will be discussed in detail in the next discussion, in the next lecture. But I want to mention some principles, because hormone replacement therapy has a big role when it comes to cardiovascular risk prevention. Earlier studies showed that estrogen treatment can be associated with cardiovascular risk prevention and lower rates of coronary heart disease, fatal and non-fatal. The Women Health Initiative trial was a long-term randomized control trial of 27,347 women. which investigated the role of estrogen given orally, conjugated estrogen, plus medroxyprogesterone, as opposed to placebo. And the second arm of the study investigated the role of estrogen-only treatment as opposed to placebo. The aim of the study was to investigate for possible death from coronary heart disease or non-fatal myocardial infarction. The study was terminated after an average of 5.6 years due to higher incidence of breast cancer. And that is when it comes to the arm of estrogen-progesterone treatment, whilst the estrogen-only arm was terminated due to higher incidence of stroke. A great fear started being apparent at that time as to whether or not menopause hormone therapy in fact increases or decreases the cardiovascular risk. Many types of analysis have taken place in order to conclude that coronary heart disease risk is better in absolute terms if the treatment is given earlier after the menopausal transition, so in younger women, rather than later. In particular, for women that were treated, it's the blue bars, with estrogen only, you can see that up until an age range of 69 years, the effect was protective. So we did not have any additional death. The Kronos early estrogen prevention study showed, in very simple definition of it, that the oral treatment, oral estrogen treatment, has a slightly more detrimental effect into the thickening of the carotid artery as opposed to the transdermal. That is why we prefer transdermal if a patient has cardiovascular risk factors. Another important study is the ELITE study, which tried to show as to whether or not the timing of giving hormone replacement therapy has implications on the cardiovascular risk. And this study showed that earlier treatment is more beneficial as opposed to treatment started later after the discontinuation of ovarian function. Same results were retrieved from a meta-regression analysis. The treatment has risks, which will be discussed later, which, however, can be balanced if the treatment is provided in the right form and the right time. Right time would mean earlier, closer to the time of ovarian senescence. So ultimately, in young, recently menopaused women, HRT exerts a beneficial effect on cardiovascular risk factors, whilst in older women with more mature atherosclerotic plaques, HRT can destabilize the plaque, leading to acute thrombotic events. Customization of the risk should take place before any decision can be made in order to give the right type of treatment. And in conclusion, menopause increases the risk of diabetes mellitus, as well as clinical and subclinical cardiovascular disease. Available evidence suggests that the severity of vasomotor symptoms is also associated with cardiovascular risk, whilst HRT can help alleviate the symptoms, reducing the risk of osteoporosis and possibly, sorry, I was timing myself, and possibly cardiovascular disease. This is my part of the contribution, and I leave the floor for the interesting discussion on what to do with regards to HRT.
Thank you very much, Elena. This was excellent, and I think there are many questions, but we will answer them at the end of the presentations. So now it's my great pleasure and honor to introduce our third speaker, Dr. Tim Hillard. Tim is a consultant gynecologist and menopause specialist at the University Hospital Dorset, Poole in the UK. He has over 30 years experience of clinical practice, research and education in menopausal urogynecology. He is a past president of the British Menopause Society and a current board member. He was a board member of the International Menopause Society during 2016 and 2022, and is currently a board member of the European Menopause and Andropause Society. Tim has organized many international congresses, was president of the EMAS Congress in London in 2009, a co-chair of the last IMS meeting in Lisbon in 2022, and co-chair of the forthcoming meeting in Melbourne 2024. He is editor-in-chief of Climacteric and he has contributed to a number of national and international guidelines. So it's our pleasure to hear about the management of menopause, including early menopause. Tim, the floor is yours.
Thank you, Irene, and welcome to everybody. It's a great pleasure to be able to speak to you this afternoon and follow on from those two excellent talks. My presentation is really going to be a practical guide for prescribing and dealing with the menopause with reference to what we've heard already. These are my disclosures, which Irene has really mentioned already. And what I'm going to discuss with you today is a little bit about early menopause specifically, and then discuss the management options, the decision making around what to use and when to use it, and then who should have MHT, what are the considerations about prescribing it, and what alternatives do we have. And obviously that's a huge topic to cover in 20 minutes, so I will go over it briefly, but very happy to take questions at the end. So the first thing to say is that the menopause is a natural event. The reason that we are so engaged in discussing with it is because it happens to every single woman. Many of us, Irene, myself, and others have been talking about this for many, many years. But until recently, it felt like a lot of people weren't listening. So it's absolutely wonderful now that menopause is in the news, it's on the national press, it's certainly in the UK, and all over the world, people are talking about it more, which is absolutely fantastic. But at the end of the day, the event itself hasn't changed. It still happens to every woman. About 20 to 30% of women experience significant symptoms that we've heard about already, which impact on their quality of life. The other 70% may well still experience symptoms which may or may not be troublesome, but some women do go through the menopause without any problems at all. It's important to remember that. We've also know about the long-term health implications, which you've just heard about, in particular osteoporosis and cardiovascular disease. But also want to focus on the fact that premature and early menopause have significant long-term health risks, which are easily correctable, and that's why they're so important. So I thought I'd spend a few minutes just highlighting what we mean by the menopause and early menopause and premature ovarian insufficiency. Early menopause is defined as a menopause between the age of 40 to 45 years and occurs in up to 20% of women, so it can be quite prevalent. Premature ovarian insufficiency, or POI as we'd call it, is when the menopause occurs before the age of 40. This spontaneously occurs in about 1% of the population, and obviously may occur more frequently in some gynecological populations where ovaries are removed for other reasons. And it's also important to recognize that a small proportion of these women are actually adolescents when they go through to become menopausal. And we're increasingly seeing survivors of childhood cancer who then reach menopause, but obviously they have become rendered menopausal by the treatment for their original cancer, which is usually not gynecological. So why is menopause so important? First of all, we get the symptoms. We've talked about the early menopause so important. They get the symptoms, the same symptoms as a woman would get at the normal age of menopause, but also there's additional stress and psychosocial factors at play. If you are going through a menopause at 30, when all your friends and peers are having children and going to the school and they're not getting these symptoms, it can make you feel very left out, particularly if there's issues around fertility. It also causes loss of self-esteem, sexuality, and fertility concerns. So those are the sort of principal symptoms that initially, but obviously we know, and we need to advise the women, that there is an increased risk of osteoporotic fracture, cardiovascular disease, and an increased risk of dementia, neurological disease, and indeed premature death. And the numerous studies now have identified that when women go through an early menopause, usually the cohorts like the Mayo Clinic cohort are surgically induced menopause, but if they go through an early menopause and they're untreated with hormone replacement, then there is a higher incidence of all of these factors within about 15-20 years, which can be correctable by the appropriate use of hormone replacement. So we'd always recommend that women under the age of 50 who are going through the menopause really should have appropriate hormone replacement at least until the age of 50, because this reduces the risk of these problems back to the baseline. In the same way as an endocrinologist would treat thyroid deficiency by giving thyroid hormone, I think loss of estrogen before the menopause, before the natural age of menopause, should be considered an endocrinological problem. So if we go on to talk more generally now about managing the menopause, then the general considerations are, first of all, it needs to look at it in its entirety. It's not just, as the first speaker said, it's not just about the hormones and giving hormones back. It's about looking at a whole life approach. And quite often, the menopause is the first time a woman actually comes to see a doctor about herself for many years. She may have been many times with her children or for other reasons, for in pregnancy, for instance, but actually when things start to go wrong around the menopause, it's often the first time someone actually comes to say, what about me? What can I do? And the menopause presents a great opportunity to look at someone's lifestyle and look at the modifiable risk factors for cardiovascular disease, for osteoporosis and the like, such as smoking, weight, BMI, diet, exercise, all these things we've talked about, and look at that. So that should always be part and parcel of any menopause consultation. But what about the treatment options for the symptoms? The first one to highlight is something called cognitive behavioral therapy, which you'll probably be familiar with. And this is a psychological therapy that is available online. It is very specific to the individual symptoms. And there is really quite good evidence that this can be very helpful for some people, but obviously you have to engage with it to get the benefit, but it can really be quite useful. And the main advantage of it is there's no risk involved. It is something that women can access, and it can be used in conjunction with other treatments, not just on its own. Hormone replacement is the most effective and proven medical treatment for menopausal symptoms, and I'm going to focus on that a bit more in a few minutes, but it's important to emphasize that not every woman needs to be on it. Then there are the complementary and alternative therapies and other prescription drugs, which I will be coming to towards the end of my presentation. So I'm going to focus on MHT for the moment and really focus on what does it do? Why would you actually take it? Well, the first and most important thing is it relieves menopausal symptoms and improves quality of life. And there's abundant evidence that it's very effective in doing that. And that is the main reason that most people will go on to it. It also reverses the urogenital changes that we've heard about and improves some of the symptoms of urogenital atrophy and vaginal atrophy. It prevents osteoporosis, reduces fracture risk. We haven't really focused on that too much, but there's pretty good evidence that it will help reduce fracture risk and is as good as other medications like bisphosphonates for doing that. And also, as we've just heard, it reduces cardiovascular disease risk. So who should have it? Well, first and foremost, women going through an early menopause, as we've said. Secondly, symptomatic peri- and postmenopausal women. When you start it, it really comes down to individual preference, but certainly women start getting symptoms sometimes in the mid-40s, and it's certain if they are getting significant menopausal symptoms associated with menstrual irregularities consistent with the perimenopause, it seems very reasonable to start it at that point. For women under the age of 60 at increased risk of osteoporosis, I think the evidence is such that it's perfectly reasonable to consider hormone replacement as the most appropriate treatment for osteoporosis prevention in that age group. Once you get to 60, I think one could argue that there's other treatments may be more effective, but certainly for women under 60, MHT is a very reasonable first-line choice. There isn't really any indication to take HRT purely for the prevention of cardiovascular disease. We could discuss this, but the overall, whilst we have clearly identified that there are benefits of taking HRT on cardiovascular disease risk, whether it's enough to say for the primary prevention that women should be taking it, I think is a subject for discussion. And nor is there enough evidence for us to say that it's going to prevent dementia, and certainly would not advocate it for that with the evidence we have available at the moment. But the most important thing is that indications and risks and benefits should be reviewed on a regular basis, on an individual basis as well. Everybody is slightly different and their risks and benefits will vary, and indeed will vary with time. So we have to look way up, as you do with any other medication, the benefits of on menopausal symptoms, sexual function, osteoporosis, etc., and the risks. And I'm going to come on to talk a bit about the risks at the moment in a minute, because these are the things that really are the main block for women taking hormone replacement therapy. Either it's a block from the women themselves or indeed from their physician. And I've put dementia in the middle because we really don't know whether hormone replacement has a positive or negative effect on it at the moment. So I think it's best left out of the equation. So the main concern that women have relates to the risk of breast cancer and hormone replacement therapy. And this is a subject that's been debated for many, many years, and there are lots and lots of studies out there, and still we don't have any clear idea. That in itself should tell us that there's no strong association. But there does appear to be a small increase in risk, and I think it's reasonable to conclude from the evidence that we have that there is a slight increase in risk with HRT, but that risk is small and it needs to be kept in perspective, and I'll put that in the next slide. It also depends on the type of hormone replacement that you use. Estrogen alone seems to have very little or no change in risk, whereas estrogen and progesterone are associated with a small increase in risk, and that may vary depending on the type of progesterone we use. So the norethisterone and MPA-based products appear to have slightly higher risk than the progesterone products like micronized progesterone or dydrogesterone. However, these are observational studies, not randomized controlled trials, so one should always be cautious about drawing too much conclusion from this. Any increase in risk in breast cancer seems to be related to treatment duration, and it returns to baseline once the treatment is stopped. And in all women, the potential risks have to be balanced against the likely benefits. So those, if someone is incredibly symptomatic and really struggling in their day-to-day life, then the benefits are likely to be much greater than someone who's only got minor symptoms. Ultimately, it becomes the patient's choice of what they want to do in conjunction with their clinician. So this is just to try and put the risk of breast cancer in perspective, and this is based on the data from the Women's Health Initiative, which we've heard about already. And on this slide, there are 1,000 women. The top line is in red, and this is the number of women. This is 1,000 women over 5 years, and these women are aged between 50 and 65. And 15 of these women would get breast cancer in the next 5 years if they didn't take HRT. The next line is the blue one, and if all of the women took combined HRT, then 19 would get breast cancer. So there will be an increase, but it is a small increase. If all of them had had a hysterectomy and just took estrogen-only HRT, 11 would get breast cancer, in other words, a slight reduction. If none of them took HRT, but they all had a BMI over 35, then 30 of them would get breast cancer. And if they all had a normal BMI and didn't take HRT, but all had 2 glasses of wine or 2 units of alcohol a day, then about 25 would get breast cancer. So you can see that whilst hormone replacement therapy can have an influence on breast cancer risk, it's one of many factors that seems to influence the risk, and therefore has to be taken into context. So the other main concern and risk is of thrombotic and stroke risk. And this is something that we would always concerned about with hormone replacement, is that oral therapy does seem to increase the risk by around 4-fold. If someone has no particular risk factors for thrombosis or stroke, then this risk of small increase in risk is not statistically significant or not clinically significant. But if someone has other risk factors such as BMI or past history, then that is significant because that extra risk could increase their risk considerably. So we recommend transdermal therapy, which doesn't appear to increase risk at all and is therefore more appropriate for women with additional risk factors. In addition, such as obesity and factor V Leiden. The risk of stroke is not increased in women under 60 based on the WHI study, and it does appear that the risk is slightly increased with oral estrogens, but not with transdermal. So again, for a process of assessing each individual on an individual basis and deciding whether or not what's the most appropriate. But for most women, oral therapy is perfectly reasonable. If there's increased risk factors, transdermal therapy is preferable. And there are numerous international statements. I'm not going to go through them all. This is just a summary of some of them, the recommendations. But basically, as far as MHT or HRT is concerned, they all more or less say the same thing, that for the vast majority of early postmenopausal women, in other words, under 60, HRT is a safe and effective option in the relief of menopausal symptoms and the prevention of osteoporosis. So just to spend a bit of time highlighting what is HRT for those of you who are a little unfamiliar. HRT contains the hormones of estrogen and progesterone. If a woman is hysterectomized, she has the estrogen on its own. If she's if she's got a uterus, then she needs to take a progesterone, which is either given cyclically, which is given as in the menstrual cycle for 12 to 14 days each month, and she has a monthly bleed, or it's given continuously once she's postmenopausal. We do have the option of using it on a quarterly basis, although this is associated with an increased risk of irregular bleeding, and also over a few years there's an increased risk of endometrial hyperplasia, so it's not recommended as a long-term option. But it does mean that we can use the progesterone in different ways to suit the individual patient. And when we're looking at the different types of estrogen, we have a whole range available now. We have tablets, patches, gels, and spray. And we either can use low dose, medium dose, high medium dose, or high doses. And this can vary depending on the recommendation of the needs of the patient. But in general principle, we would recommend starting with a low dose treatment and starting to increase as necessary, very much dependent on the patient and their symptoms and the other risk factors we've discussed already. It's worth highlighting that younger women often require higher doses and older women often require lower doses, and you can titrate that as time goes on. It's also important to recognize that the vaginal symptoms that we see are not always improved by systemic estrogen, particularly at lower doses, and additional vaginal estrogen preparations may be necessary. Progesterone is the main aim of the progesterone is to prevent endometrial stimulation and hyperplasia. So if you don't have a uterus, you don't need it. It can be given cyclically, as I said, or continuously. There's quite a lot of discussion at the moment about people using high doses of estrogen, and in this situation we'd recommend that we probably ought to increase the dose of the progesterone as well to compensate the effect of the increased estrogen dose on the endometrium, although evidence for this is lacking at the moment. Side effects are common with progesterone, but they're often dose dependent, and there are different types of progesterone available: norethistone, MPA, dydrogesterone, progesterone, and some others in other countries. And there will be different side effect profiles with each one. So if somebody is struggling with one, then you try a different one. There are also different routes. You can have, most of them are oral, but you can use the transdermal norethistone in the patch. There is also vaginal progesterone, and of course the Mirena IUS, which is a great option for perimenopausal women in particular, as this gives them cycle control and also provides contraception, as well as being licensed for MHT opposition. Vaginal estrogens are an important separate entity, and they're not technically MHT. They are a separate entity. They are estrogens given vaginally, and they can be given indefinitely. They are very safe. There is plenty of evidence that there really is no stimulation of breast or clotting factors with vaginal estrogens, and therefore it's perfectly reasonable to use. There is no routine endometrial needing for endometrial monitoring or progesterone withdrawal, and they can be used in conjunction with MHT if they need be, if the symptoms are not being controlled. Obviously, they can be used with moisturizers and lubricants as well, and for some women that would be the first line treatment before starting vaginal estrogens, but vaginal estrogens can be used in addition to those products. What about testosterone? Lots of common questions about testosterone, and we've seen some evidence about the changing in testosterone with time. It's important to highlight that there is a gradual decline with age, but there's no specific change at the menopause. About 50% of testosterone in women is produced by the ovaries. So in women who've had their ovaries removed surgically for whatever reason, then there's possible that that can have an additional impact. And most of the original work on testosterone in women was done in women who'd had their ovaries removed. There is proven efficacy that testosterone can help with reduced libido, but there is no clear evidence for any other benefits. Again, there's a lot of claims that it can help other things like fatigue, sleep, brain fog, but there's been numerous studies looking at this, and the global consensus position statement from Sue Davis and others published in 2019 made it clear that there is no clear evidence that it has any other benefits at this stage. There's ongoing research looking into this, and that may change, but at the moment we don't think there is. In terms of safety, as far as we can see, testosterone used at the right dose is safe, but we don't know the long-term risks because the studies have not been done. Tibolone is the only licensed testosterone product and is licensed for the improvement of libido, and it's always worth considering. The other products are not licensed for women, and their availability will vary from country to country, but certainly Androfem, which is the dedicated one for women, dosed for women, is not certainly available in the UK, and I don't think it's available in the rest of Europe except through private prescriptions. So just want to finish off by spending a couple of minutes looking at the other options if hormone replacement therapy is something that the patients don't want or is not appropriate. There are a whole range of alternative and herbal remedies and complementary therapies, and I don't have time to go through these in detail, just simply to highlight that a lot of these have very limited evidence to back them up. There really haven't been a lot of placebo-controlled trials, and in those that have, placebo doesn't appear to be any inferior, with a placebo response up to 50%. There are also very little data on the safety and the drug interactions of these products, and therefore one should be very cautious about introducing them, particularly in people who have other risk factors. Of the two remedies that have been studied, alternative remedies, red clover and black cohosh appear to be the most studied and are the most likely to have a benefit, and are certainly used quite widely in some countries. Acupuncture may also have a role and has got some reasonable evidence behind it for some of the symptoms. But what about the non-HRT pharmacological agents? And these ones have been around for a while. Clonidine is always been cited because of one early study some years ago, but really it doesn't appear to be any better than placebo. Side effects are common and has a risk of causing hypertension. Propranolol is a beta blocker, which doesn't really seem to help very much in the majority of the situation. Venlafaxine does appear to have some benefit in short clinical trials, but is an antidepressant, and a lot of women are against taking an antidepressant, even when you try and explain that that's not why they're taking it. Gabapentin, you'll be familiar with, is quite a heavy dose drug, but it does seem to have some evidence in reducing hot flushes and can be useful at appropriate doses. And oxybutynin, which is very familiar to those of you who work with women with pelvic floor problems, is actually been shown to have some benefit in hot flushes as well. But obviously the problem with oxybutynin is that it does often cause quite a lot of side effects, but it can be another alternative. But the other option we've now got available, which has recently become available in Europe, is the neurokinin 3 antagonists. These, I haven't got time to go through this in detail, but basically this works on the what they call the candy hormones, kisspeptin, neurokinin B, and dinormin, which are involved in the reproductive cycle and the autonomic thermoregulatory pathway via the median preoptic nucleus. This leads to a heightened NKB, NK3R signaling associated with the menopause, and the NK3 antagonists block these receptors and therefore reducing the risk of vasomotor symptoms. And there have been a number of clinical trials now out there which have shown that this really is quite effective. This is the study from Juliet Prague, which is the original study in the Lancet 2017, and there have been phase 3 clinical trials now, and it's now fezolinetant from Astellas has now been given FDA and EMA and MHRA approval and is now available in the clinical field, and it does seem to be effective and is well tolerated. So for those people who don't want to take hormone replacement therapy or can't take it, then this could be a very reasonable alternative option which will improve vasomotor symptoms. Effects on other symptoms have not really been studied. So just to summarize, managing the menopause can improve quality of life and reduce long-term disease burden. And as clinicians, we really should be advising women appropriately on what's best for them. A lot of women suffer with the menopause and don't get advice and support, or get misadvice and support, and we really need to make sure they get the right advice. It's important that promoting a healthy lifestyle should be an integral part of any discussion. As far as treatment is concerned, MHT is an effective and largely safe option for the majority of peri- and postmenopausal women. Vaginal estrogens can be used alone or with MHT as long as necessary. And fezolinetant is a non-hormonal option, which is now available and shows promise in clinical trials. So thank you very much for your attention, and I'm happy to take questions. Further information available.
So thank you very much, Tim. Excellent presentation. And we will proceed now to the Q&A because we have a lot of questions. Our first question, I think it is addressed to Andrea. Does adrenal hormone production also decrease due to menopause? Andrea, can you please answer the question?
So, sorry, can you repeat the question? Sorry.
Yes. Does adrenal hormone production also decreases during menopause?
Yes, sure. A little bit, and is a reduction that is not the same of the ovarian reduction. So adrenal in menopause become the first producer of androgens, DHEA, sulfate, NDHA, and androstenedione and testosterone. So it's the the leading producer of androgens, while the ovarian function is during the menopausal transition is lower and lower, and then is pretty zero. So the decrease of adrenal function is limited respect to ovarian function.
Thank you.
Right. Thank you. So now we have a lot of questions. I think we can morph some of the questions into one broader question where all the panelists can discuss. There's a question about switching different HRT or MHT modalities related to aging. So during the time span that there is given. And also there's a question before that, which is related, when is too late to introduce therapy? And also maybe we can add on this, when do you usually stop? So we can just see if how the panel feels about these questions.
So it's a question for me. So I think that we can start HRT even 10 years after the menopause. But a WHI study make us very to put attention on these of the time of the start of the therapy. Anyway, we can know that if you start early, it's better. But if you can start even after 5 or 6 years, you must have a good counseling with the patient and to find the right therapy for this kind of women, for the peculiar person. So you can check for symptoms, for relative and absolute contraindication. Then you can start even 6 years after the menopausal event. And for sure, if you have a maybe partial or absolute contraindication, you can treat and prevent osteoporosis and even cardiovascular disease, and to maintain an active lifestyle. This is the most important aspect.
Thank you. And Professor Hillard, maybe you could also add about switching regimens through the age as it progresses. What would be your thought on this?
Yeah, I think it's important to keep reviewing it. Certainly, when someone is in the sort of early 50s, one would be looking at reasonable doses. But as someone gets a little bit older, one would try and reduce the dose of estrogen to see if that will still have the same benefit. Often it does. I think I would normally recommend that around the age of 60, although it doesn't have to be exactly 60, you have a discussion with the patient about, what the plans are for the future. Quite often women will gradually sort of default on the treatment because they don't want to take too much. But if they're still getting benefit, then there's no reason why they can't carry on with it a bit longer. And some people carry on taking it for a lot longer. But I think one should always reappraise the dose and not just keep someone on the same dose forever.
Yeah, exactly. And do you sometimes switch from oral to transdermal and then keep them for a longer and then?
Yeah, I think overall we think the risks with the transdermal are less, and therefore it's probably more appropriate by the time you get to 60 to switch to transdermal therapy. But we do get some women who really like the tablets and they get on with it. So, if they want to stay on it and you've done a risk appraisal, it's not impossible to do that. It's just patient choice, really.
Right. Thank you.
So the next question, which is also controversial, I think, is about cognitive decline in HRT. So we have data from premature menopause that the HRT prevents cognitive decline, but we have also the WHI data for women over 65, which say that HRT increases the risk of dementia. Tim, would you like to comment on this?
Yes, it's, as you say, it's a very controversial topic. I think we don't have enough data to be able to draw all the conclusions. We can say, we can speculate. I think the problem with early menopause, as we highlighted, is that is a definite problem that has long-term consequences, and therefore we should correct that. The WHI data was looking at women often over 60 starting hormone replacement therapy, and in those group it didn't make any difference. In fact, it might even make it worse. And it's probably to do with the vascular changes that have already occurred within the brain by the time they were starting hormone replacement. We don't know that for sure, but I think the message is that for women who are going through an early menopause, definitely it's worth considering taking hormone treatment to help reduce that risk. But there's nothing to be gained by starting women who are much older on HRT to try and prevent dementia, and indeed that might be counterproductive. But I think there's a lot of data we don't have to answer all the questions on that.
But I think we can conclude that for women transitioning normally to menopause, let's say around 50, HRT is perfectly safe for their cognition.
It's perfectly safe for their cognition, but whether it reduces their risk is another question we don't know.
Thank you. So we have a question also for Elena, something that is also, I think, very important for all of our listeners. It's regarding to overweight patients, patients with hypertension, and also patients with lipid disorders. You discussed on this also, but maybe to elaborate more on especially which patients you can introduce therapy to, which not, regarding these three things.
Definitely, thank you. I think the way to go ahead is try to stratify the cardiovascular risk. That means absence of cardiovascular risk factors, complete absence. You can use any algorithm that is desirable, any local algorithm according to the country you're living, in order to stratify the cardiovascular risk. If the risk is low, you can give any type of hormone replacement therapy if the patient wants and needs, according to the indications, hormone replacement therapy. If the cardiovascular risk is moderate, that means 1 to 2 risk factors like dyslipidemia or hypertension or diabetes, then it's better to go for something safer from cardiovascular perspective, which would be transdermal. If you have many cardiovascular risk factors, which would reflect into high risk or perhaps a recent heart attack, then it's better not to suggest HRT. And if you really want to suggest HRT, to explain to the patient the risks, the cardiovascular implications of HRT under those circumstances. Vaginally is obviously preferred in comparison to oral or transdermal in this group of patients, and try to limit the duration of treatment in order to avoid deterioration of the cardiovascular risk. Monitoring of the risk factors at the same time of the treatment is also indicated.
Thank you. And also when we think about, for example, combining with statin therapy, what is your view on this? Since we know that MHT is not sufficient to regulate the lipid disorders, however, in combination with statin therapy, it provides benefits.
Absolutely. This has to be prioritized. So the cardiovascular risk needs to be prioritized over the control of the menopause symptoms if we're talking about the most eligible treatment. Secondarily, focusing on the menopause symptoms, we can suggest hormone replacement therapy, provided the patient fulfills the indications. But the cardiovascular management has to be the first line in a patient that suffers from true cardiovascular event.
Thank you.
I think we have another question for Elena. So heartbeat, palpitations, and tachycardia are common symptoms of the menopause, and often women go to cardiologists first. So is there a mechanism of autonomic dysfunction which happens during the perimenopausal transition? If yes, do we manage it?
So
Elena?
Thank you. According to the latest data that I was reviewing, there are so many factors to contribute into developing palpitations at the time of menopause, like the hot flashes, the night sweats, the intake of caffeine, the lifestyle, the mood disorders, the poor sleep, that the true pathophysiological mechanism behind sex hormone-related palpitations has not really been established yet. With regards to managing it, I would prioritize the cardiology way of managing, because stronger conditions that can contribute to palpitations need to be excluded before we blame the menopause. But I'm also open to any more suggestions in case there is anything more recent available.
Thank you. So we also have a question regarding therapy in women with POI and also history of thromboembolic events. This is also, I think, interesting, maybe very useful for our listeners.
So with regards to POI, we need to remember, as I think both of my co-speakers said, POI is an insufficient function of an organ at an age where it should actually be functioning. As you cannot deprive a woman of levothyroxine if the thyroid is not working, At the same time, you should not deprive of estrogen, progesterone, provided there is a uterus, at an age where the ovary should be working. The theoretical risk attributed to hormone replacement at a level before the age of 50 is negligible. So irrespectively if there is thrombotic risk, I would not be concerned to give hormone replacement therapy in a woman as such, unless there is a true DVT or PE on the background, where I would opt for the friendlier regimen, which would be the transdermal. And also control other factors that would increase the thrombotic risk, like obesity or potentially lifestyle. But what the books say at this moment is that the thrombotic risk in a woman that experiences POI is pretty much so low that we should not be concerned to replace the function of an ovary. It's similar like reestablishing the woman into a state of normal ovarian function. And obviously we can also consider giving biosimilar progesterone, which has a friendlier cardiovascular effect. I'm actually referring to natural progesterone, which has the most friendly effect to the cardiovascular system rather than the more synthetic versions of progesterone, if we want to minimize any implications.
Thank you, Elena. And there is a very interesting question addressed to Tim. So since vasomotor symptoms are associated with increased cardiovascular risk, if we prescribe the new neurokinin antagonist drugs, will we decrease the cardiovascular risk?
Well, it's a good question, but I don't know the answer. One might do, but I think it probably comes down to, is it the fact that the women who get vasomotor symptoms are more inherently at risk of cardiovascular disease anyway, or is it the vasomotor symptoms that increase the cardiovascular disease risk? And I don't think we know the answer to that. More research. Come back in a couple of years and maybe we can answer that question.
Thank you. And for Andrea, a question, do we have some information about cognitive symptoms in early menopause and cognitive symptoms in general in menopausal women, and how to, and when to treat it?
Yes, these kind of symptoms are some of the first symptoms that are presented because the menopausal transition is something that change deeply the mood of women. So sometimes is related to the sleep quality of the disruption of the sleep quality, and maybe women can be tired, can be deteriorated by some change to sexual life. So these kind of symptoms are related, yes, for sure, for neurotransmitter and some hormonal changes, but also for by personal experience and the situation, the discomfort of vasomotor symptoms in working place, the discomfort of sexual activity with the partner. So these kind of symptoms are related at the beginning of the menopause to different several aspects of biological and personal life. Can be treated, yes, for sure. If you treat the hypoestrogenism, if you try to maintain a good quality of life, activity, and you can improve the working place and working activity, and you can focus on relationship. So yeah, if you try to prevent all these kind of symptoms, you can improve that.
Thank you.
There is another question addressed to all three speakers, I think. Is there any randomized, not observational data on the cardioprotective effect of transdermal or low-dose oral HRT regarding the heart outcomes, as coronary heart disease or cardiac death? Who would like to answer this? Tim?
I'm just trying to think. I'm not sure there's any randomized data on. I think there was one very small study on transdermal therapy, but I mean, in terms of looking at major outcomes, you need big studies, and you know, as we all know, the WHI was supposed to be the sort of definitive study, which never really answered the questions it was going to. And I don't think we'll ever get a study like it again, unfortunately. So, you know, it'd be great to repeat it with transdermal estrogen and a micronized progesterone, but, you know, who's got the funding, I'm afraid.
Agree. We have a lot of intermediate outcomes, but no hard outcomes.
Yeah.
Yeah. Thank you.
And thank you. Another interesting question is treatments and gynecological cancer. So cervical cancer, ovarian cancer, I think this again would be very useful. And of course, this is a question for all three speakers, so you can participate in this. Who would like to add?
I'm quite happy to start on this one. We're actually just about to produce some guidelines on it in the UK, but I think for the non-hormonal dependent cancers like cancer, that's like cervix and vulva, it's really not an issue. You can use hormone replacement as needed. With ovary, most ovarian cancers are not sensitive to estrogen, so you can use it. But if you have a granulosa cell tumor and the different endometrioid carcinoma, then you would have to be a bit more cautious. The main issue really revolves around endometrial cancer. And the feeling of the oncologists is really that actually, if it's a stage 1 disease, which often it is, then it's not unreasonable to consider hormone replacement therapy. There is an unknown issue about whether to add in progestogen or not, and it's interesting in our discussions that I've always favoured adding in a progestogen to cover the possibility of any ectopic endometrial tissue, but the oncologists seem less concerned about that. So given the potential adverse effects of progesterone on breast and possibly metabolic effects, then you know, maybe we don't need to do that. But I think for most women it's perfectly feasible, but it does require specific assessment of the histology.
And remaining on that topic, Andrea, would you like to answer the next question about topical estrogen therapy in women after breast cancer?
Yeah, it's this kind of patient, it's very difficult to treat. I think that in a particular case, you can administer this kind of therapy if the symptoms are very heavy and the quality of life is very low. Because for our experience, it depends about the oncologist you work with. And there is many countries, if we not consider the guideline, it's difficult to propose hormone, even topic hormone to this patient, because some oncologists can affirm that it is safer the laser and to different therapy, but I think that these are not effective like estrogen. And we use in some patients when there is a good counseling, when there is around her a team of oncologists and caregivers that can interact with us and to explain that this kind of therapy is safe and is very helpful for useful for quality of life. So we use, but there is a big difficult to maintain this kind of treatment for all these women. It's very difficult for us.
Thank you.
Thank you. One more question.
One more question. Yeah, I see a very, I think, also interesting and important question. It's about starting therapy in women with climacteric symptoms, however, still irregular but present cycles. So I think this is also one of the messages we should convey, is that despite the fact that menopause is defined as absence of menstrual cycle, we need to consider symptoms way before and introduce therapy way before. So I would like to hear also maybe from the panelists regarding this.
Well, I'm happy to start on that one. I mean, I think the perimenopause is exactly right. It's a time when symptoms start to occur. Often they're at their worst, actually, in the early phases, and it's entirely appropriate to start hormone replacement therapy at that time. Quite often, this is a group of women who have their symptoms ignored or not ignored, or told them it's due to other things, because, as you've said, the cycle is still present. But if the cycle is becoming irregular and they are therefore in the perimenopause, then I think it's entirely appropriate to start hormone treatment. You just have to be careful about choosing the cyclical regime rather than trying to give them a continuous regime, because they will have irregular bleeding otherwise.
And if can I add something our experiences? So we use in many patients the pill, because now we have several compounds, for example, estradiol valerate and natural estrogen with progesterone that we can use in the fourth decade. As you know, one of the most important symptoms and one of the first important symptoms is the change of menstrual characteristic. So and frequency. So you can use all this kind of pill, maybe during all the menopausal transition. And usually we are not interested in the menopausal event. We are interested in the menopausal transition without any symptoms. It's clear that patient that experience changing in the menstrual cycle at 48, maybe she is in perimenopausal period, and you can administer pill even until 53, and you can't discover that she is in menopause, and then we can change. Maybe we can use IUD with the levonorgestrel with estrogen on with the transdermal estrogen is something that you can use. There are several compounds.
So thank you very much. The discussion is really interesting, but we have to complete the webinar. So I would like to take this opportunity to thank the three speakers for their excellent presentation, the attendees for their insightful questions, the two societies, the European Society of Endocrinology and EMAS for organizing this event, and of course KAT for the excellent technical support. Thank you all for your attendance.
Thank you, everybody, and see you very soon in some future interesting topics. Have a great rest of the week.
Thank you.
Thank you so much.
Thank you. Goodbye.